Hello everyone, this is Abhishek Pandari. I am covering preventive medicine that is usually asked in USMLE Step 2 CK and Step 3. This is the second topic we are covering, and it's on metabolic and all other age-related screening. So today we'll be covering screening related to abdominal aortic aneurysm, osteoporosis, hyperlipidemia, diabetes, hypertension, unhealthy drug use, unhealthy alcohol use, intimate partner violence, and depression. Coming to abdominal aortic aneurysm screening, the candidates are men of age 65 to 75 years of age who have ever smoked. Even if they have smoked a single cigarette in their lifetime, they are qualified for this screening. The method of screening is abdominal ultrasound with Doppler, and the frequency is a one-time screening. So this is about abdominal aortic aneurysm. Coming to osteoporosis, in average risk individual, the candidates are usually all female at age 65 years of age, and the screening method is using DEXA scan. It is also a one-time screening method. There are certain individuals who have increased risk of osteoporosis, and these individuals need screening at or before 65 years of age. In cases of postmenopausal women of less than 65 years of age with increased clinical risk of fractures, they are usually screened before 65 years of age depending upon the risk of fractures, and the risk of fractures are usually estimated via using formal clinical risk assessment tool like FRAX scoring. In case of premenopausal women with known secondary cause of osteoporosis, or if they have a history of fragility fractures, then these individuals are qualified for screening for osteoporosis using the DEXA scan, even if the age or menopausal status is not met. And this third line is in consideration with the guideline from International Society of Clinical Densitometry. However, it is not based on USPSTF, which we will be covering most of the time. These are some clinical risk factors for fracture, like glucocorticoid therapy, history of fracture, low body weight, advanced age, previous history of fractures, cigarette smoking, alcohol consumption, rheumatoid arthritis, and other secondary causes of osteoporosis. Coming to hyperlipidemia, in individuals with average cardiovascular disease risk, they are usually screened for lipid disorders, and males are started screening at age of 35 years of age, while females are started at 45 years of age. The frequency of screening is every 5 years if the lipid results are normal, and every 3 years if they are abnormal. They are usually screened by fasting lipid profile. In individuals with high risk of CVD, cardiovascular disease, that is, those individuals who have a history of hypertension, diabetes, cigarette smoking, or family history of premature coronary artery disease, then the screening starts at an earlier age. For male, it is at 25 to 30 years, and for female, it is 30 to 35 years of age. In children and adolescents, there is insufficient evidence currently to assess the balance of benefits and harm for screening of lipid disorders in children or adolescents less than 20 years of age. Coming to diabetes screening, people are usually screened with diabetes. Those who have BMI more than or equal to 25 kg per meter square, that is meaning if they are overweight or obese and are at the age of 35 to 70 years of age, then they are usually screened for diabetes with using fasting blood sugar or 2-hour oral glucose tolerance test or hemoglobin A1C. And frequency is not well defined. However, the USPSTF gives a 3 yearly as a reasonable guideline to screen them. Coming to hypertension, In average risk individuals, that is adults of age 18 to 39 years of age without any other comorbidities or predisposing factors for hypertension, they are usually screened with office blood pressure measurement every 3 to 5 years for the presence of hypertension. But in individuals with increased risk, like age more than or equal to 40 years, Black Americans, persons with high normal BP, that is pre-hypertension, overweight persons or obese individuals, then the frequency is increased to annual office blood pressure measurement. Unhealthy drug use. Candidates for screening of unhealthy drug use are adults of age 18 years or older, regardless of risk factor for unhealthy drug use. Each and every individuals are screened for unhealthy drug use. The method is asking one or more questions about drug use or drug-related risk in face-to-face, print, or audiovisual format. Especially the screening tools are applied for the screening of unhealthy drug use, and some of the screening tools are like NIDA tool, 8-item assess tool, TAPS. These people are not screened on the basis of biological specimens for the presence of drugs like urine, saliva, or stools. They are just screened by using a fixed set of questionnaires, predetermined questionnaires. The frequency for screening of unhealthy drug use is undetermined. It depends upon the predisposition for unhealthy drug use and the convenience of the practitioner for screening of unhealthy drug use. One thing to note is that screening tools are not meant to diagnose drug dependence, abuse, addiction, or drug use disorders. Patients with positive screening results may therefore need to be offered or referred for diagnostic assessment. And in adolescents, there is current evidence is insufficient to assess the balance of benefits and harms of screening for unhealthy drug use in adolescents. Similarly, coming to unhealthy alcohol use, the recommendations for screening for unhealthy alcohol use is similar to unhealthy drug use. Adults of age 18 years or older, regardless of risk factor for unhealthy alcohol use, are screened, and the screening tools are fixed set of questionnaires, validated set of questionnaires like Audit-C and SASQ. There is little evidence of how frequently people should be screened of unhealthy alcohol use. It also depends upon the predisposing factor for unhealthy alcohol use and the convenience of the practitioners as well, and the practice of the hospital or clinic. In adolescents, the current evidence is insufficient to assess the balance of benefits and harms of screening for unhealthy alcohol use. Coming to intimate partner violence, the candidates are women of reproductive age group without recognized signs and symptoms of abuse. Methods are again various sets of tools that are based on questionnaires like HARC, HITS, E-HITS, PVS, and WAST. These questionnaires are usually directed to women of reproductive age group. Again, the frequency is undetermined in this case. It also depends on the scenario of the presentation of females and the socioeconomic background, and also that depends upon the practice of the clinics and hospitals and the practitioners. Certain predisposed individuals are regularly screened. However, the frequency is undetermined, and it is kept on to the practitioner to determine the frequency of screening. Coming to depression, the candidates are adults of more than equal to 18 years of age. The method of screening is again the patient health questionnaires. like hospital anxiety and depression scales in adults, geriatric depression scales in older adults, and Edinburgh postnatal depression scale in postpartum and pregnant women. The frequency and time is undetermined again in case of depression as well. Screening all adults who have not been screened previously and using clinical judgment in consideration of risk factors, comorbid conditions, and life events to determine if additional screening of high-risk patients is warranted. So that's all for today. We have covered various metabolic and other social plus psychological age-related screening in this second topic of preventive medicine. On our next topic, we'll be covering on infectious diseases screening in adults. Till then, have a great day. Comments are welcome, and see you soon. Thank you.